Hello and good evening to all. Welcome to the third session of this ECG, and this will be the final session. And we request all the doctors to go through this presentation, and at the end, we request you to ask the question. Please note down your all the doubts and ask at the end. Thank you. And over to Dr. Sudha ma'am.
Hello, good evening.
Good evening, ma'am.
Yesterday, we started with the abnormal morphologies in the ECG and explained you about the how to identify the abnormal ECG components and their significance, including heart rate, heart rhythm, cardiac axis, P wave, QRS complex, and the PR interval. Today we will discuss about the abnormal ST segment, T wave, U wave, and the QT interval. As we all know that this is the normal ECG with its waves, P wave, QRS complex, T wave, PR interval, PR segment, ST segment, and the QRS complex and the QT interval, and this is the J point. Now let us start with the ST segment. This is the normal ST segment starting from the S wave, that is the J point, to the beginning of the T wave. This ST segment, as we all know, that is isoelectric and it is at the same level of PR interval or the PR segment. This ST segment normal duration, it will be less than 2 to 3 small squares, that is 80 to 120 milliseconds. This ST segment is the plateau phase of the depolarization of both the ventricles, right and the left ventricle, where the heart muscle maintains their contraction to pump the blood. So it is always flat, isoelectric section of the ECG, and it represents it is between the J point and the T wave. The most important cause of the ST segment abnormality is whether elevation or depression, myocardial ischemia or myocardial infarction. So what is the significance of ST elevation? And how you will say that ST segment is elevated? Elevation of the origin of the ST segment, that is the J point, with the QRS complex of about more than or equal to 1 millimeter in 2 or more limb leads or the precardial leads coming from V4 to V5 is significant, or when it is more than or equal to 2 meters in 2 or more precardial leads, that is from V1 to V3. How you have to measure the ST segment? This is the ST segment, all we know that. Usually, as I told you, this ST segment lies in the same level of PR segment. So, you have to take this PR segment as the baseline. This is the normal ST segment. Here, we have taken this this one PR segment as the baseline. In case of ST segment elevation, here the ST segment is elevated. You have to count from the J point, make a horizontal line. This will be the magnitude of ST segment elevation. When it is ST segment is depressed, then you have to take this as the this is the segment. This is the ST segment depression. This is the normal PR segment. So you have to take the horizontal line at the PR segment and then the horizontal line at the J point or the PR segment, ST segment. Then this will give you the magnitude of ST segment depression. So what are the characteristics of ST segment elevations caused by ischemia? There are different types. This is the convex type. This is straight upsloping. This is straight horizontal. This is straight downsloping. This commonly in the ST segment elevation during the myocardial ischemia, you will see this convex or straight horizontal. But in the straight upsloping, it is the myocardial infarction. Rarely you see this straight downsloping. There is some problem with the slide, so only you are not able to read this one properly. This is the straight downsloping. It is, this variant is usually unusual. Coming to the ST segment depression, here is the PR segment. This has to be the ST segment, but it is depressed. So you have to measure this magnitude of ST depression like this. This is known as the ST segment depression. So what are the different types of ST segment depression as per the American Heart Association criteria? Here you can see the upsloping. Here it is horizontal. Here it is downsloping. What its significance? In case of upsloping, that is more than 1 millimeter, it is most of the time it is 30 to 40% error rate. That means abnormal. Horizontal, very low error will be there. So most of the times when you see the ST, a non-ST elevation MI, you will see this horizontal ST depression. This is the downsloping ST depression. Here you will see more than 1 millimeter depression will be there. After the QRS complex, this sloping will be around more than 1 millimeter in length. So what causes this ST depression? The sloping method, that is sloping up, this is the normal, this is the sloping up, is caused by the, and normally also it is present in the lead 1, lead 2 and B3 to B6. It is also common in people with the physical exercise and sometimes associated with the hyperventilation. This is the horizontal ST depression, very common in ischemia. This is the sloping down type of ST depression, common in ischemia, especially it is associated with the inverted T waves. Here you can see the U wave. When it is horizontal, that is this ST depression is horizontal along with the flattened T wave. It's common in hypokalemia, electrolyte imbalance condition. Here you can see a convex shape of ST segment. This is commonly seen in patients with digoxin use. This is the slide showing when there is injury to the heart muscle. This is the type where only the subendocardial injury occurs. This is denoted or represented by the ST depression. When the injury is epicardial or transmural, then you will see the ST elevation. Coming to the reciprocal changes in MI, usually whenever in myocardial infarction, whenever any surface of the heart is involved, that is infarcted by the supplying coronary artery, the changes will appear in those particular leads. But at the same time, opposite to that area, that is opposite to that area involved by the MI, shows some other changes, that is known as the reciprocal changes, commonly observed in the ventricular wall. As I told, opposite to the involved wall, there will be a involved wall of the transmural injury. This increases the specificity of STEMI, that is ST elevated myocardial infarction. I will show you the further slides. In anterior wall MI, the reciprocal changes will occur in the inferior leads. Whereas in inferior wall MI, the reciprocal depression is seen in the lateral leads. Here you can see, this is the ECG showing the acute ST, that is STEMI, associated with the simultaneous ST depression in the electrically opposite leads. In case of inferior STEMI, that produces reciprocal ST depression in AVL and lead 1. This is the AVL. This is the reciprocal changes. This is the inferior wall showing the ST elevation in lead 2, lead 3 and AVF, and showing the reciprocal changes, that is the ST depression in lead 1 and AVL. This is the slide showing the anatomical groups which represents the particular area of the heart. See, this lead 1 and V5 and V6 represents lateral wall of the heart. Lead 2, lead 3 and AVF represents inferior wall of the heart. Whereas the septal is represented by V1 and V2, anterior, V3 and V4. Here I have showed you in clear, this is the lateral, this is a high lateral, and this lead 1 is the lateral and reciprocal for the inferior. Here I am showing the involved wall and the reciprocal wall. So in lateral wall, if the lateral wall is involved, lead 1, lead 5 and lead V6, and the reciprocal for the inferior. Same lateral wall, that is lead 1, V5 and V6. When the inferior wall is involved, that is lead 2, lead 3, AVF, you will find the reciprocal changes in the other lead. Like if it is inferior wall, you will see the reciprocal changes in the lateral walls, that is V5 and V6. I hope you people are understanding. I have mentioned both here only, that the wall of involved and the reciprocal wall. Coming to the anterior wall, V3 and V4 are the leads which are involved in the anterior wall. At the same time, these walls where the ST segment depression occurs in posterior wall MI. Let us know which artery is involved in which type of the myocardial infarction. ಇದೆಲ್ಲ ತಪ್ಪಾಗ್ತಿದೆ. will change. ಅದು PDF ಮಾಡ್ತೀರಾ? PDF ಹಾಕಕ್ಕಾಗಲ್ಲ. ಮಾಡ್ಬಿಡಿ. Actually, there was some there is some technical issue. I'll take 5 minutes break, please. Okay. Sorry for the interruption. In this slide, you can see the artery which is involved in the particular wall of the myocardial infarction. In lateral wall of myocardial infarction, the left circumflex vessels are involved, showing the ST elevation in V2, V5, V6, lead 1 and AVL. And septal wall MI, septal branch of left anterior descending artery, leads are V1, V2, lead 1 and AVL. Whereas in anterior wall MI, the left anterior descending artery, one of the major coronary artery, is involved, producing the ECG changes, that is the ST elevation in lead 1, AVL and V1 to V4. Whereas in extensive anterior wall MI, that is the left main coronary artery is involved, producing the changes in lead 1, AVL and V1 to V6. Coming to the posterior wall MI, the artery involved is posterior descending artery most commonly. Otherwise, the left circumflex artery also can be involved, causing the ST elevation in V7, V8, V9. This is also the same slide. This is also the slide showing the arteries involved. Here, what I told you in the lateral, circumflex, circumflex, and the circumflex, V5 and V6. In the inferior right coronary artery, lead 2, lead 3, and AVF. In the anterior part, this is anteroseptal. It is left anterior descending artery. This is how you can see the localization of the various parts of the heart. Here you can see the blue one, that is septal, V1 and V2, and this is the orange. This is the showing anterior, that is V4, V3 and V4. This is the lateral wall of the heart, represented by lead 2, lead 3 and AVF. Now let us see with the STEMI or ST elevation MI. In this ST elevation MI, what you have to look for? You have to look for the ST elevation in the continuous 2 leads. This ST elevation should be more than 1 millimeter, and at the same time, where you have to look for this ST elevation? You have to see when the in lateral STEMI, you have to look for lead 1, AVL, V5 and V6. In anterior, V1, V2, V3 and V4. In inferior STEMI, you have to look for lead 2, lead 3 and AVF. Coming to the ST segment changes, that is the ST segment elevation during a STEMI or ST elevation MI. Within hours, there will be pronounced T wave initially. This T wave is elevated with the ST segment elevation. Here it is convex type. This is the convex type. Within 1 hour to 24 hours, 1 to 24 hours, there will be depressed R wave. This R wave will be elongated, longed here. It will be depressed R wave will be there with the enlarged or pronounced T wave. And this pathological Q waves may appear within hours, or it may take greater than 24 hours, indicating the full thickness MI. This Q wave appears whenever there is full thickness infarction. This Q wave is pathological if it is wider than 40 millimeters or deeper than 1/3 of the QRS complex. Please note here, this Q wave is pathological only when the width is more than 40 milliseconds and the height, it is deeper. It is more than 1/3 of the height of the entire complex. On the day 1 to day 2, there is exaggeration of the T wave continues. After few days, the T wave inverts as the ST segment. See here, all the ST segment. This is the ST segment you can mention. This is the PR segment. You have to measure from the J point to the horizontal line extended from the PR segment. This is the elevation of the ST segment. So this ST segment elevation begins to resolve. But in some cases of ventricular aneurysm, this ST elevation may persist. This is how the ST segment has started resolving. After few weeks to months, ECG returns to the, in the ECG, the T wave returns to the normal wave. And the ST segment, minor ST segment elevation will be there, but retains this pronounced Q wave. After the 1 to 2 days, this Q wave start increasing in its size. And after the weeks later, there will be a pronounced Q wave. This is how the old infarct looks. Coming to the anterior wall STEMI, this is the anterior ECG strip showing the anterior wall anterior wall STEMI. So what are the, as I told you, in the anterior wall, you have to ST segment elevation will be there in the lead V3. This is the V3 and V4. If the septal involvement is there along with the anterior wall, V1 and V2 also will be involved. What about the reciprocal changes? In case of anterior wall MI, this is the V3 and V4 ST elevation is there. Okay, this is the ST elevation is there. Whereas the reciprocal changes are seen in the inferior leads, that is lead 2, lead 3 and AVF. Here you can see the ST segment. This is the PR segment. Here you can see better. This is the PR segment and this is the horizontal line. This is the ST segment depression. So this is the amplitude of ST segment depression. So I have told you that reciprocal changes in the anterior wall STEMI will be seen in inferior leads, that is lead 2, lead 3, AVF, whereas the ST segment elevation is seen in V3 and V4. This is how this is the anterior wall caused anterior wall MI due to the occlusion of the proximal left anterior descending coronary artery, showing the ST elevation in V3, V2, V3 and V4, whereas ST depression in lead 2, here it is almost horizontal. The reciprocal changes will be seen in lead 3 and AVF. This anterior wall STEMI can be extensive. That is, extensive area of the anterior wall STEMI occurs whenever there is complete occlusion of the supplying artery. So there is massive ST elevation, commonly known as the tombstoning pattern. Tombstone morphology is present throughout the precardial leads, that is V1, V2, V3, V4, V5 and V6. You can see the how these are there. This is the QRS complex. This is the R. This is known as tombstone appearance in the extensive anterior wall stemi. This pattern is seen as a result of proximal LAD, that is left anterior descending artery occlusion, indicates a large territory infarction. This is the ECG showing hyperacute anteroseptal STEMI. In this anterior wall with the septal, where you have to see the ST elevation, V1, V2, V3 and V4. See, all here you can see the ST elevation. With the hyperacute T waves, this is the T wave. This is the ST elevation, hyperacute T waves. See, this is almost normal T wave. Here it is hyperacute T waves. And ST elevation will be there in lead 1 and AVL with the reciprocal ST depression in lead 3. Here you can see the ST segment depression. This is the PR segment. This is the above, around more than 2 small squares. This ST depression is there in the lead 3. Q waves may be present in the septal leads, that is V1 and V2. These are the features of hyperacute anteroseptal STEMI. Coming to the inferior wall STEMI, what are the ECG findings you will see? I have already told you that in the inferior wall MI, the ST segment elevation will be seen in the lead 2, lead 3 AVF, and the reciprocal ST segment depression is seen in the lateral leads, that is lead 1, AVF and V5 to V6. We'll show now. This is the inferior wall STEMI, where you can see ST elevation in lead 2, lead 3, V5 and V6, and reciprocal T wave inversion in lead 1. You can see in AVL properly, and the lateral leads. This is the depression, ST segment depression. Those are the reciprocal ST segment depression. This is the inferior wall MI showing the reciprocal depression in the AVF and ST elevation in lead 2, lead 3, AVF and V5 and V6. Here you can see the ST elevation, whereas the ST depression in lead 1 and AVL. Here you can see the ST depression. Here it is almost normal. Coming to the lateral wall STEMI. In this lateral wall STEMI, you will see ST elevation in the lateral leads, that is lead 1, AVL and V5 to V6. At the same time, you will find the reciprocal ST depression in the inferior leads, that is lead 3 and AVF. When the ST elevation is primarily localized to the lead 1 and AVL, normally it will be lead 1, AVL V1, V5 and V6. In case of high lateral STEMI, this ST elevation is localized to only the lead 1 and AVL. I will show you the next slide. I will be showing the extensive lateral wall STEMI. So, this lateral wall is supplied by the branches of anterior descending artery. So, whenever there is occlusion or atherosclerosis of the left anterior descending artery and the left circumflex artery, you will come across with the lateral wall STEMI. So, isolated lateral wall STEMI is always very less common. So, most of the time, this infarction of the lateral wall occurs as a part of other larger infarction like anterolateral STEMI. So, you will find the lateral wall STEMI as the extension of either anterior, inferior or the posterior wall MI. So, what are the categories of lateral wall or lateral STEMI? There are three types of lateral STEMI. This is anterolateral, infero-posterior lateral and isolated lateral. I have told you already, this isolated lateral is very less common. So, this is the ECG showing anterolateral STEMI. So, what role you have to see in the anterolateral STEMI? There will be ST elevation in the anterior leads, that is V2, V3, V4. So, you can see the ST elevation. This is the ST elevation. And presence and lateral leads. Lateral leads are lead 1, AVL and V5 to V6. So, it is a combination of lateral walls plus anterior wall, that is anterolateral STEMI. Q waves are present in both anterior and the lateral leads. Here you can see a small Q wave. It's very small. Okay, both. This is the, anterolateral STEMI causes the ST elevation in both the anterior and lateral anatomical leads. At the same time, there will be a reciprocal ST depression in the inferior leads. Inferior leads are identified as lead 3 and AVF. You can see the ST depression here. And AVL and AVF. This is the AVF here. And here you can see the ST depression. ST elevation in lead 1, AVL, V5, V6, V2, V3 and V4. This constitutes the interpretation is anterolateral STEMI. Coming to the high lateral STEMI. Here the ST elevation is present high in the lateral leads, that is lead 1, AVL. I have already informed you that in the lateral wall STEMI, lead 1, lead AVL and V5 and V6 will be involved. In case of high lateral STEMI, only lead 1 and AVL are involved. That is, there will be a large or elevation of the huge elevation of the ST elevation is present in the lateral leads. This is the lead 1 and AVL. With this, there will be hyperacute T waves. When I'm going to explain you about the T waves, I'll show you again how the hyperacute T wave looks. Here you can see the hyperacute T waves. Here also. Here. Okay. Here in this high lateral STEMI, the culprit vessel is the first diagonal branch of left anterior descending artery. let us see about the posterior wall STEMI. This posterior wall STEMI is suggested by the changes in V1 to V3. That is, there will be tall, broad R-waves will be there and upright T-waves will be there, and the presence of ST elevation and the Q waves in the posterior leads, that is V7 and V5, and horizontal ST depression will be there in the reciprocal leads. This usually this posterior wall MI patients presents with the ischemic symptoms, and there will be a horizontal ST depression in the anteroseptal leads. Those are that is the reciprocal leads. You will find V1 to V3 that there will be horizontal ST depression will be there. So as I told you, in the posterior wall MI, ST segment depression will be there. That is, the reciprocal depression will be in the septal and anterior, and the elevation in the posterior leads V7 to V5. I'll show you how you have to place the lead V7, V8 and V9 in the next slide. And ST elevation in the inferior leads, lead 2, lead 3 and lead AVF may be seen if along with the posterior wall, inferior wall also involved in the MI. Most commonly, posterior with the inferior wall will be involved. Here you can see how you can place this is the front of the chest, lead 1, lead 2, lead 3, lead 6, where you have to place the lead 7, lead 8 and lead 9. You have to, in the back of the patient, you have to place lead 7 between lead 6 and lead 8. Lead 6, you all know that it is in the 5th intercostal space in the mid-axillary line. 8 is at the tip of the scapula in the 5th intercostal space. So, lead 7 electrode you have to place between lead V6 and lead V8. That is the electrode in the tip of the scapula. Coming to the lead 9. Here you have to place the electrode just lateral, just left to the spine. This becomes your electrode for the V9, and this electrode will become for V8, and this is V7. So as I told you, there will be depression in the anterior leads, that is the reciprocal depression in the V1 and V2, V3. Here you can see the ST segment depression is there, whereas ST elevation is there in the long strip. This is the lead 2, there will be ST elevation will be there, and you will be seeing the ST elevation in the posterior leads V7 and V9. Here you can't see this. I have not showed you the V7 and V8, V9. I will show you the typical appearance of T-wave ST segment depression in lead 2. See, lead 2 also have lead 2 in the posterior wall infarction. See, this is the V2. How you can see the ST depression? This is the lead 2. This is the ST depression. This is the typical appearance of posterior wall STEMI in the lead V2. Coming to the ST segment, what happens in to the ST segment in myocardial ischemia? That is, there is no infarction, it is only the infarction. Ischemia has occurred in the particular wall of the heart. Here, in case of myocardial ischemia, you will see only the ST segment depression. And along with the ST segment depression, there will be this T wave will be symmetrical. Normal T wave is asymmetrical. But in myocardial ischemia, it will become symmetrical. Normal is asymmetrical. In ischemia, it becomes symmetrical and tall V wave will be there. At the same time, your QT interval also will prolong. There will be long QT interval. Here you can see, as I told you, here you can see these are the places where you can see the ST depression. Here you can see the ST depression with the symmetrical. This T wave is symmetrical. Usually the normal T wave is initial is sloping. The initial half is sloping. The next half will be normal. Here it is symmetrical. Here also you can see the ST depression and the QT interval from the Q wave to the T wave. This is the QT interval is also prolonged. Now let us know about the non-STEMI, that is non-ST elevation MI. In the non-ST elevation MI, ECG shows ST depression with the T wave inversion, and both ST and T wave inversion, that is if there is only ST depression, the sensitivity is around 70 to 80%. If there is only T wave inversion, it is only 10 to 20. When it is both both ST depression and the T wave depression, T wave depression, the sensitivity will be 100%. Here you can see the non-ST elevation, that is non-ST elevation STEMI, otherwise N-STEMI. N-STEMI is also known as subendocardial or non-Q wave MI. Here the Q wave is not enlarged or it will not pronounced in the case of non-ST, non-STEMI. Okay. In this non-STEMI patients, usually present with the acute coronary syndrome or in which the ECG does not show ST elevation, only the ST depression will be there. Here you can see the ST depression. That is the horizontal ST depression. This is the ST segment, horizontal ST segment, and this is the up sloping T wave. I will explain you again when I am going to explain you about the T wave. And the Q and the ST elevation will never happen in non-ST elevation MI. That is non-STEMI. You will not find either Q wave or ST elevation. If you are in doubt to confirm the non-STEMI, you have to do the troponin test and you have to find out whether it is an MI or it is unstable angina pectoris. Coming to the ECG in chronic MI or in a long-standing MI patients, how the ECG looks. This is the normal wave, normal ECG, and this is the chronic ECG of the chronic MI patient or prolonged or long-standing MI. Here, there is no Q wave or very small Q wave is here. In lead 2 only you can able to see the Q wave properly. So it's very small. Here, as a result of long-standing MI, the MI has been resolved, but it will leave, there will be retainment of the pathological pronounced Q wave. Here you can see the Q wave. See, this is the Q wave. This is the Q wave. Here is the very prominent Q wave is there. This is the Q wave. let me tell something about the Brugada syndrome. It is a hereditary syndrome marked by the right bundle branch block and the ST segment in the right precordial leads. What is the peculiarity of this Brugada syndrome is this ST elevation looks like saddleback or covered. ST segment, this is the ST segment, this is the T wave. This ST segment is covered. There are three types are there, but prominently and the proper covered ST segment is seen only in the type 1. So when it is, when here you can't see the proper covered ST segment, in such cases you require further evaluation. But this type 1 is the diagnostic pattern of Brugada syndrome. You can see the ECG showing the Brugada syndrome. Brugada ECG waves. In lead V1, V2, V3, here you can see the Brugada wave. Oh, sorry, this is V3, this is type 2, this is type 1, type 2, type 3. Here you can see the proper Brugada waves, V1, V2, V3, that is type 1. It is the diagnostic feature of Brugada syndrome. In case of type 2 and type 3, it is not prominent covered or saddle back shape of ST segment. Now, let us talk about T wave. We all know that normal T wave is asymmetrical and the first half is more gradual slope. Here you can see the first half is gradual, whereas the second half is not gradual compared to the first half. This T wave should be less than 2/3 amplitude of the corresponding R wave. And this R wave and this T wave amplitude rarely exceeds 10 millimeters. And at the same time, when the T wave is symmetrical or tall or peaked or biphasic, it becomes abnormal. I will show you in the next slide what are the different types of T waves. This is the normal T wave. This is the peak T wave. This is the ST segment elevation along with the T wave elevation. Here also you can see, here also. And here the Q wave formation will be there, and there is loss of R wave. There is no R wave and only the Q wave is there. And here you can see the T wave inversion. As I told you, when the T waves are diagnosed as tall waves, their amplitude will be more than 5 millimeter in the limb leads, whereas in the precordial leads, they should be more than 10 millimeter. Then only you can say that the T waves are tall. What are the causes for tall T wave? Sometimes it can occur in the normal patients also. And most common cause for the tall T wave is acute coronary syndrome and hyperkalemia, especially when the serum electrolyte is serum potassium electrolyte is more than 5.5 milliequivalents per liter. Here you can see the tall T waves. So, causes are, as I told you, acute MI, acute coronary syndrome, hyperkalemia and hypermagnesemia. Where you find this T wave inversion? Normally, we all know that all the waves are negative or inversion in AVR, but T wave may be inverted in along with AVR V1 also in the normal patients. In young patients, this T wave can be inversion. Inversion of the T wave can occur in younger people also in V2, and in case of black people, it will be in V3 also. Most common cause for the T wave inversion is myocardial infarction along with the myocardial ischemia, ventricular hypertrophy, digoxin toxicity, pericarditis, hypokalemia. This T wave elongation of the T wave or the pronounced T wave will be seen in the hyperkalemia, whereas in hypokalemia, T wave inversion will be seen in case of anemia, thyroid and beriberi. So coming to the acute coronary syndrome, as I told you, there will be tall, hyperacute T waves will be seen as the early sign. Increased T wave height may occur in the acute coronary syndrome as a result of potassium being released from the damaged myocytes, leading to localized hyperkalemia. Here in acute coronary syndrome, not only the coronary artery occlusion, there will be localized hyperkalemia which leads to hyperacute T waves. Hence, tall T waves are the characteristic feature of acute posterior myocardial infarction or acute coronary. It is one of the type of the myocardial infarction most commonly seen with the tall T waves. In the infarction of posterior wall MI, the reciprocal changes, that is, will be viewed in the anterior chest leads. I have told you anterior chest leads as the ST elevation in lead V3, lead V2, V3 and V4. Thus, when there is myocardial infarction with the appearance of Q waves, with the appearance of ST segment elevation and the T waves are inverted, then you can say that patient is in acute coronary syndrome. This is the ECG showing acute coronary syndrome. You can see hyperacute T waves. At the same time, here ST elevation in lead 3 and here ST segment depression. Coming to hyperkalemia, as we all know that when the serum potassium level is more than 5.5 milliequivalents per liter, it is known as hyperkalemia. In case of hyperkalemia, there will be the ECG shows tall tented T waves. There will be widened and tented T waves will be present. Along with the tented tall T waves, in hyperkalemia, you may also see flattening or even loss of P wave, and along with lengthening or increased PR interval, widening of QRS complex as the serum potassium level increases from 5.5 to 7, 7.5, 8, then you will get a sine wave of T waves. And there will be shortening of the QT interval. PR interval increases, duration of the PR interval will be increased. At the same time, there will be shortening of the QT interval. This hyperkalemia leads to the serious complications like ventricular fibrillation or asystole. So, whenever you see the hyperkalemia features in ECG, confirm immediately with the serum electrolyte, serum potassium levels, and start the treatment as early as possible, because this hyperkalemia leads to severe complications causing arrhythmias like ventricular fibrillation or asystole. So here you can see how the typical ECG showing the T wave, typical T wave changes. When it is mild, that is 5.5 to 6.5 milliequivalents of potassium, you will see peak T waves and prolonged PR segment. When it is moderate, that is 6.5 to 8, there will be loss of P wave will be there, prolonged QRS complex and ST segment elevation. This is the ST segment elevation. This is the baseline. So here is the baseline. So this is the ST segment elevation and peaked or tall T waves are there. When it becomes severe, that is more than 8 milliequivalents per liter, you will find this sine wave. This is the sine wave shape. There is progressive widening of the QRS complex producing the S sine wave. This is a serious condition where you have to treat the patient immediately. Otherwise, they will progress to the complications like ventricular fibrillation, asystole, and vesicular blocks or complete heart block. So this is the ECG showing hyperkalemia with tall T waves. Here you can see the tall T waves. Here, the serum potassium level is around 9.9 milliequivalents per liter. You can see the sine wave. I have told you, this is the sine wave. So whenever you see the sine wave, almost in all the leads, limb leads and the precordial leads, you can find out this sine wave. Whenever you see the sine wave, it is a case of severe hyperkalemia. Coming to the inverted T waves. Till now, we have come across with the enlarged or peaked T waves. Now, we will discuss about the negative or the inverted T waves. Here, this is the T wave inversion, most commonly symmetrical T wave inversion, most commonly seen in post-ischemic patients. Here, the T wave inversion is there, but at the simultaneously, the ST segment depression is there. Here, the ST segment depression is not there. There is normal ST segment, but prolonged QT interval is there. When there is normal or isoelectric ST segment with the T wave inversion, it suggests post-ischemic. When there is ongoing or acute ischemia, there will be T wave inversion along with ST segment depression. In case of cerebrovascular insult, where the patients are having the intracerebral hemorrhage, you can see the deep gigantic T wave. See, this is T wave inversion is there, but compared to this, it is okay. But here you can see the gigantic T wave inversion is there. Coming to the hypertrophic cardiomyopathy, you will see the symmetrical T wave inversions commonly in lead V1 and V2 will be there. In case of perimyocarditis, T wave inversions occurs after the normalization of the ST segment. Here, the ST segment has become normalized. It has become isoelectric. It is at the level of the PR segment. Where you find small T waves. In case of hypokalemia, pericardial effusion and hypothyroidism, you see small T waves. Along with the small T waves, in case of hypokalemia, when the serum potassium level is less than 3.5 milliequivalents per liter, you will find small T waves along with the first degree heart block and the depression of the ST segment, and there will be appearance of prominent U wave. Here you can see the ST depression, shallow T wave and the prominent U wave. And P wave is slightly peaked. And there will be slight prolongation of the PR interval also will be there. Here you can see the hypokalemic features like here you can see ST segment depression with the small T wave, and here this is the prominent U wave. What happens when the digoxin toxicity occurs? Along with the reverse thick ST segment depression, T wave inversion is also present in the digoxin toxicity. So, whenever the patient is on digoxin, frequently at a periodical interval, you have to take the ECG of the patient to know whether there is any T wave inversion indicating that there is digoxin toxicity. If the digoxin toxicity is a possibility, you have to ask the patient about the other symptoms also. At the same time, you have to check the potassium serum potassium levels, because arrhythmias are more likely to occur if the patient is along with the digoxin toxicity, if the patient is having hypokalemia. This is the characteristic feature of ST segment. This is the sagging type of ST segment. You can see this is the ST segment. This is the T wave. You can see this is the sagging morphology of the ST segment. Here you can see the ST segment sagging here and here. So, where do you see this biphasic T waves? There are two main causes for the biphasic T waves: myocardial ischemia and hypokalemia. In case of myocardial ischemia, T waves go from up to down. See, T waves has gone from up to down. This is the biphasic T wave. From here to here is the T wave. Up to down. Whenever there is up to down biphasic type of T wave, you have to think of myocardial ischemia. When there is a T wave goes from down to up. Here you can see it is down. This is the ST segment. T wave has, this is the T wave from here to here. This has gone, first it has gone down, again it has become up. This indicates hypokalemia. So biphasic T waves you can see in hypokalemia and acute myocardial ischemia. In case of myocardial ischemia, it is up to down. In case of hypokalemia, it is down to up. Now let us know about the U wave. We all know that U waves are the, here is the U waves. Normally, U waves goes in the same direction as the T wave. Size of the U wave is inversely proportional to the heart rate. This U wave becomes prominent in when the heart rate is low, that is in bradycardia. But this U wave is not visible when the heart rate is more. That's what it becomes visible if the heart rate falls below 65. Normally, the voltage of U wave, that is the amplitude of length of the U wave, U wave is 25, should be less than 25% of the T wave. This is the T wave. This is the T wave. This is the U wave. It is less than 25% of the T wave. Maximum normal amplitude is 1 to 2. Here, the small squares I am telling you, it should be amplitude of 1 to 2 small squares. That is, each small square, as all of you know that each small square amplitude is 1 millimeter. So, 1 to 2 small squares, that is 1 to 2 millimeters. What are the abnormal U waves look like? There will be prominent U waves and inverted U waves. Prominent U waves are seen as the when the amplitude is more than 1 to 2 millimeters or more than 25% of the height of the T wave. Coming to the causes of prominent U waves, most commonly seen, I have told you, U waves becomes prominent only when the heart rate is low, that is in bradycardia, at severe hypokalemia. Other causes includes hypocalcemia, hypomagnesemia, hypothermia. You have to note down here, in hypothermia, there is prominent U waves are there along with the QT variations. And in case of raised intracranial pressure, left ventricular hypertrophy, hypertrophic cardiomyopathy, and in patients on following drugs, you can see the prominent U waves, like patients with digoxin, phenothiazines, class 1A anti-arrhythmetics, class 3 anti-arrhythmetics. In these patients, you may find prominent U waves. Here you can see the prominent U waves. This is the prominent U wave. Here you can see lead V3 and V4. This is the T wave, prominent U wave in sinus bradycardia. Coming to the inverted U waves, this U wave inversion is abnormal. Normally, the U wave is in the same as the upright of the T waves. Whenever there is inverted U waves are present, you have to think of underlying heart diseases, because a negative U wave is highly specific for the heart disease. Common causes include coronary artery disease, hypertension, congenital heart disease, cardiomyopathy, hyperthyroidism. So whenever the patients comes to you with the history of chest pain and with the inverted U waves, this is an indication for underlying myocardial ischemia. So you have to consider further evaluation of the patient. It may be the earliest marker of unstable angina also, at the same time evolving myocardial infarction. So this is the ECG showing unstable angina. You can see the U wave depression. That is inverted U wave. Coming to the QT interval. QT interval starts from the beginning of the QRS complex to the end of the T wave. So it represents both ventricular depolarization and ventricular repolarization. So it includes QRS complex, ST segment and the T wave. What do you mean by QTC? This This QT interval is always affected by the heart rate. When the heart rate is more, it will become, this QT interval becomes small. When the heart rate is slower, this QT interval becomes long. That is, longer when the heart rate is slower or shorter, and shorter it will be there. And hence, whenever you measure the QT interval duration, it should be corrected with the heart rate. Hence, you mention it as QTC. What is the importance of QT interval? Whenever there is prolonged QT interval, there is increased risk for the ventricular arrhythmias, especially torsides de points. And it is also, the prolonged QT interval is also seen in congenital short QT syndrome and congenital long QT syndrome. In case of congenital short QT syndrome, it is associated with paroxysmal atrial or ventricular fibrillation, leading to both these conditions, torsides de points and the ventricular fibrillation, is associated with a increased and severe complications like sudden cardiac death and the ventricular fibrillation. So, how you can measure the QT interval? It is usually measured in the lead 2 or V5 and V6. However, the measurement, the longest measurement, whether it is in the lead 2 or lead 5 or lead V5 or lead V6, the longest measurement should be considered. Whenever you are taking the measurement of the QT interval, several successive beats has to be measured. I have told you, you have to associate, or you have to consider this QT interval with the heart rate as controlled or QTC, that is controlled with the heart rate. There will be large U waves, that is more than 1 millimeter. Most of the time fused with the T wave should be included. I'll be showing you in the next slide how you have to measure the QT interval. See, this is the QT interval. This is the QT interval, different types of T waves. Here it is normal, here it is biphasic. Here how you have to measure smaller U waves and those are separate from the T wave should be excluded from the measurements. If there is very small T wave changes are there, you can exclude them. But when there is prominent T wave changes are there, such as large U waves, this is the U wave, fused, here it is fused. When it is fused with the T wave, you have to include the U wave also. Here you have, this is the tall U wave combined with the T wave. So you have to include the U wave also when you are measuring the QT interval. Though the QT interval represents or measures, we have to measure the QT interval from Q wave to the T wave. When there is large U wave with the T wave, you have to include the U wave also. So what are the causes for prolonged QT interval? There will be congenital long QT syndrome, hypokalemia, almost all the electrolyte imbalances with the lower level of electrolytes, that is hypokalemia, hypomagnesemia, hypocalcemia and hypothermia is prominently, you can see the prolonged QTC in hypothermia and hypokalemia, and the patients on certain drugs, myocardial ischemia and the ROSC post cardiac arrest, that is Here, this is the ROS post cardiac arrest when there is return of the spontaneous circulation. Cardiac arrest has occurred, but followed by the reversal of the restoration or the return of the spontaneous circulation post cardiac arrest. And whenever the patients are presented with the raised intracranial pressure, acute myocarditis, cerebral injury, you will find this prolonged QTC. This is the ECG of hypokalemic patient showing the QTC level. Here you can see this is the Q wave and this is the end of the T wave. This QT duration is being prolonged. Hypokalemia along with the QTC prolongation, there will be prominent U waves in the precordial leads. Here is the precordial leads. This is the T wave. This is the U wave. You can see here prominent U waves. Here also you can see the U wave. This is the T wave. This is the U wave. Here you can see the QT interval is very much prolonged. That is, QTC is longer duration, about 620 milliseconds, especially in the severe hypothermia patients. Most of the times, these hypothermic patients with the QT prolongation are associated with the bradyarrhythmias, especially the slow atrial fibrillation. As the hypothermia becomes severe, there will be presence of Osborne waves and the shivering artifacts will be there. But most of the times, this prolonged QTC will return to its normal once the hypothermia is corrected. Coming to the congenital long QT syndrome, you can here also you can see the prolonged QT interval. In this congenital long QT syndrome patients, they are associated, they will present with the associated features like torsides D pointus pattern, that is ventricular fibrillation, and they are prone for the sudden cardiac death. What are the causes of short QTC, that is less than 360 milliseconds? Most common causes are congenital short QT syndrome and hypercalcemia. Even in hyperkalemia, hyperthermia and digoxin toxicity, you will find this QTC, short QTC, but more prominent in hyperkalemia. Here you can see the congenital heart QT syndrome showing very short QTC, that is QT interval. Here, see from here to here, it is very short, around 280 milliseconds, along with the peak T waves. T waves are peaked. This is the QT interval, very small. These are the here you will take QTC interval is short, but peaked T waves are present. It is a autosomal dominant inherited disorder of the potassium channels. Hence, it is associated with the increased risk of paroxysmal atrial or ventricular fibrillation and increased risk of sudden cardiac death. As I have told you, most prominently seen in hyperkalemia. These QT intervals are very short, that is less than around 260 milliseconds. Here you can see Q to the T. QT interval is very short. Hyperkalemia leads to the ST segment, shortening of the ST segment. Here you can't see the ST segment only here. and may be associated with the Osborne waves. I have mentioned you about the Osborne waves in hypercalcemia and also when I was talking you about the hypothermia ECG. Okay, what is this Osborne wave or J wave? Etiology is, as I told you, commonly seen in hypothermia and hypercalcemia and with patients with certain medications and ventricular fibrillation. These Osborne waves, also known as the J waves, are most prominently seen in the precordial leads. This is the lead 5 showing the Osborne wave. This is the Osborne wave. Here you can see this is the Osborne wave. Usually it resolves when it occurs in hypothermia. Usually this resolves with vomiting. It is not doesn't have any prognostic value. You can see here the Osborne wave. This is the J point. Here you can see the Osborne wave. This is the elevated ST segment. Here is the elevated ST segment along with the Osborne wave. Thank you. Now the session is open for the discussions or any doubts. ಇದು mute unmute ಮಾಡ್ರಿ.
Hello, ma'am.
Yeah, tell me.
Sir, regarding V7, V8, V9, what should be the position of the patient if you are keeping these leads? In
What?
standing posture,
What you are
because
saying?
actually, so in V7, V8, and V9, no, we told, ma'am.
Yeah.
You told.
Yes.
So in that condition, what should be the position
No,
of the
supine position
patient?
only. Supine position only you have to keep. Always the ECG should be monitored in the, should be taken in the supine position only.
So whether that can be kept in posterior side and taken the...
Yes, no problem.
Okay, so all the 6 plus 3 extra should be added?
No, normally we don't require. But in case of posterior wall STEMI, this ST elevation, ST segment elevation is seen in the posterior leads. That is the V7, V8, V9. So in such cases, when you are suspecting, then you have to take those leads also.
Only those 3 leads we have to...
Yes, not only 3. Everything you have to take.
Okay.
Along with the this one, anterior leads also, precordial leads also.
Okay. So in ECG, whether both hypo and hyper can be identified by seeing the ECG?
Hypo or hypo?
Hypothyroidism and hyperthyroidism.
No, you can't
Both.
see. You can't see. Hypothyroidism produces the different waves and hypothyroidism you find different. If the patient is already on the treatment, you will see the mixing up of few of the wave pattern changes will be there.
Okay, whether by seeing the ECG, whether we can identify whether the patient is having hypothyroidism or hyperthyroidism. That's what my question.
You can't. These are some of the features. Once you have diagnosed the patient as hypothyroidism or hyperthyroidism, these are the additional features which you can see in those patients' ECG. That's all. With the ECG changes, you can't diagnose the patient as hypothyroidism or hyperthyroidism. You have to go for the thyroid profile.
Okay, thank you, ma'am.
Yeah.
If anyone is having any other questions, please, you can ask now.
Hello, ma'am.
Yeah, tell me, ma.
Ma'am, what are the ECG changes can seen in carpulmonale, ma'am?
Carpulmonale, see, that depends upon it. It will be having the right ventricular hypertrophy. So you will be seeing the changes of the right ventricular hypertrophy along with the pulmonary hypertension, because carpulmonale patients will be having the pulmonary hypertension. So for each diseases, I am not showing any changes and all. It will be depending upon the other associated cardiac problems. You will be finding the ECG changes.
Yes, ma'am. Okay, thank you.
Ma'am,
Yeah, tell me.
ma'am, in regular practice, which are the most common conditions where we have to note this ECG changes, ma'am?
Okay, I'll tell you. When in the most common is acute myocardial infarction. That is ST segment. What different types of MI have told you, STEMI and non-STEMI. Okay, in those cases, you have to see the ST segment is one of the most important parameter you have to look in the ECG. If there is any ST segment elevation, you have to in more leads, like I have told you, the anatomical groups I have told you, in which are the leads showing the ST segment elevation and the ST segment depression. You have to consider those leads and you have to suspect whether the patient is in the early phase of myocardial infarction or whether he has already entered into the myocardial infarction state. Everything you have to monitor. You want to see the slide what I have showed you?
No, ma'am. It's I understood that point. Okay,
so one is myocardial infarction, other one is hyperkalemia. When especially in the ICU patients, when you are monitoring continuously, if you see the T-wave changes, you have to ask for the immediate serum electrolyte levels. In hyperkalemia patients, hypokalemia, you asked me about what are the main conditions where you have to look for the ECG changes.
Yes,
one is the myocardial infarction, electrolyte imbalance, especially the hyperkalemia and hypokalemia. And where else you can see?
Heart block.
And heart blocks. Most important is the heart blocks. Yesterday I explained you about the different types of heart blocks. First degree heart block, second degree heart block, and the third degree or the complete heart block. In the first degree heart block, you will see the PR interval will be constant. Okay. Whereas in the second degree type 1, that is Morbid's type 1, PR interval goes on increasing to a certain dropped P wave, and in Morbid's type 2, where the block occurs at the level of the AV bundle, Morbid's type 2 is very important. When you see this one PR interval goes on remaining constant, but there will be a disappearance or the dropped P wave, you have to think of Morbid's type 2 or the second degree heart block. And when you see the complete heart block, it is one of the emergency situation where you have to initiate the artificial pacemaker implantation. Otherwise, patient will go for the sudden cardiac death. So, MI, electrolyte imbalance, heart blocks, and arrhythmias. Most commonly important diseases where you can identify with the ECG is ventricular, arrhythmias. It can be atrial arrhythmias, bradyarrhythmias, tachyarrhythmias, ventricular arrhythmias, ventricular tachycardia or ventricular fibrillation, where you require the immediate intervention. There is no time for you to decide what treatment you have to give. When you see that there is a pattern of ventricular fibrillation, what you have to do? You have to defibrillate immediately. Otherwise, patient may go for the sudden cardiac arrest and you will lose the patient. So, MI, electrolyte imbalance, heart blocks, and arrhythmias. commonly you will come across with these patients. When there is, as I told you, when there is extensive heart blocks, especially in complete heart block, patient will go into the cardiac arrest, asystole. When coming to the ventricular fibrillation also, patient will go for the sudden cardiac death. When there is severe hyperkalemia, as I told you, more than 9 milliequivalents per liter, patient will go for the ventricular fibrillation. So, all these situations requires early intervention of the underlying condition. Anything else?
Excuse me, ma'am.
Yeah, tell me.
Yeah, ma'am, what are the other, when we are in doubt with ECG, what other investigation, like ma'am, tropi when it is indicated,
Yes.
or
Yes.
treadmill or angiography like that, ma'am?
Yes. See, nowadays, we have started in the emergency room, no? We have started with the fast scan. That is, immediately when the patient presents to the emergency room, ward or emergency ward, you will be connecting the patient to the all the parameters and you will take the ECG and all. If you are having any doubt, you have to do the immediate echo of the patient. In this echo, doing the fast scan, we call it as the fast scan. In that cases, you will come to know, is there any wall motion abnormalities are there. Most of the times when the patient presents with the myocardial infarction or acute coronary syndrome, you will see the, depending upon the type, depending upon the which wall has been infarcted or is going into the ischemia or infarction, you will find the reduced wall movement. That is, wall movement of those ventricles will be reduced. So you have to do a fast scan as early as possible, along with this thing, sending the blood for the further investigations.
Other ma'am, then when the tropi and this treadmill indicated, ma'am, and angiography also.
Angiography, if that trophy becomes positive and all, you have to take. If the ECG is showing you the proper ECG changes, nowadays we'll taking the patient for the primary angioplasty. When you decide on with the ECG that patient is having the anterior STB, take the patient directly for the primary angioplasty. No point of waiting whether it has been already evolved MI or anything and all. Seeing the underlying changes, ST elevation and ST depression, you have to take the patient directly for the primary angioplasty. No point of waiting the patient to develop or to get the your blood tests done and all. Most of the times it will be positive. There is no point in waiting for the blood tests also. If you are confident, if you are sure that the patient is having the MI, please take the, you can refer the patient to the cardiology unit of your hospital and the patient can be directly shifted to the cath lab for the primary angioplast. Most initially, long time previously and all, we used to wait for patient to get symptomatically free and all. Now there is no point if the patient is having acute chest pain with the ECG changes, we can take the patient directly for the primary angioplasty. And when you don't have the facilities for this, you can give a initial dose of start dose of aspirin with clopidogrel. This most of the time
loading dose.
Yes, start dose, loading dose of aspirin and clopidogrel you can start. If you don't have the facility of cardiac unit in your hospital or if you are practicing in a clinic, start immediately you give. If you are having the doubt, give the start dose. That is the loading dose of aspirin with the clopidogrel and you can send. Sometimes you can, people will tell, but I don't practice giving the heparin or starting the streptokinase injection in your clinic also you can start, but it is associated with the bleeding disorders and all. I mean, bleeding problems you can face with the patient and all. So it's better to give the loading dose of aspirin and clopidogrel. Anything else?
Any other doubts, doctors?
Okay. If there are no other doubts and all.
No, hello.
Yeah, ಹೇಳಿ.
Actually,
Ma'am,
Yeah, ಹೇಳಿ.
when we can do this dopamine stress test or stress treadmill tests and all?
No,
On what indication?
You can't do the test when the patient is having acute chest pain. That is the symptoms of myocardial infarction along with the ECG changes. You are not supposed to do the treadmill or anything because the patient may collapse.
Correct.
No
Okay,
point. That's what earlier days they used to wait for the myocardial changes, ECG changes to resolve, and then taking the patient for the treadmill and all. Nowadays we don't wait for the resolving of the ECG changes. So if the patients are having the cardinal symptoms of coronary syndrome, acute coronary syndromes, along with the ECG changes, you can take directly for the primary angioplasty.
Very good.
You can save the life of the patient because the involved vessels, whether the branches of the left coronary artery or the right coronary artery, whether it will be the total occlusion or atherosclerosis of the 90 to 95% of the atherosclerosed coronary arteries, you can do the primary angioplasty. You can put the like a stent, and you can reperfuse the involved myocardial wall. So once the reperfusion occurs in the infarcted area or the ischemic area, there won't be much problem. That means the heart chambers, that particular underlying wall starts contracting normally, resulting in the good pumping activity of the heart.
any other questions?
Hello, ma'am.
Hello.
Yeah, tell me.
Ma'am, can we identify triple valve disease in ECG, or we have to go for 2D echo, ma'am?
No, ma, you have to go for the 2D echo.
Okay.
Valvular diseases only in the mitral stenosis, you can see the changes, ECG changes. As I told you, like a P pulmonale will be there in the pulmonary hypertension. P mitrale will be seen in the severe mitral stenosis and all. Those are the few features you can be seen in the underlying diseases, cardiac diseases. Yesterday I told you about the P wave changes. No, in that I showed you P mitrale. In that, the P mitrale will be present in the left atrial hypertrophy along with the mitral stenosis. Whereas the P pulmonale will be seen in the right atrial hypertrophy along with the pulmonary hypertension. If no more questions, we would like to close the session. Thank you all once again for your active participation.
To all the doctor, as we have already messaged you, as there is one announcement by Dr. Varun Kumar, who is a senior surgeon and general and laparoscopic surgeon. He is a director of Kishan Vidya Academy. Wants to announce one information. I request Dr. Varun Kumar to announce it, sir.
Hello. Thank you, ma'am. Thank you so much
Thank you.
for your
Thank you, Varun.
presentation, and thank you so much, ma'am. Hello.
Yeah, tell me, Varun.
ಅಷ್ಟೇ ಮ್ಯಾಮ್, ಅಷ್ಟೇ. ನಾನು ಇವ್ರ ಹತ್ರ ಮಾತಾಡ್ತೀನಿ, ನೀವು ಕಂಟಿನ್ಯೂ
Okay, pa. Thank you.
ಥ್ಯಾಂಕ್ಸ್.
Thank you, ma'am.
Thank you.
Hello,
Thank you, ma'am.
Thank
Yeah.
you.
Friends, we want to have a feedback from your side, one thing. And the second thing is we want to once again conduct the same class. If your friends or anybody interested, maybe it will be in the next month end. We are doing the same class with the same consultant again. And we also started one more class maybe in the second week of the August, that is on pulmonary function test, ABG analysis, and chest X-ray. It's complete pulmonology. That if anybody is interested, you can enroll here also. And another thing is we have started the second batch of PGDEMS. This is a postgraduate diploma in emergency medical services for AYUSH doctors. We have already started a batch where we got around 126 enrollment into 3 batches we did. So if anybody is interested, we'll give the further details in the group. You can take over, you can try that also. And another thing is I want to take free class on sutures, okay, so basic suture materials and where it will be used and all. So that I will shortly announce the date. That will be a free class because I'm conducting, and if you can tell your friends so that they can make use of it. So thank you so much, all of you.
Varun sir, we have one request. Can you elaborate about the benefits of that postgraduate diploma in emergency medical services to our team?
So that is an add-on course. Like, see, I have done my MBBS, I have done my DNB. After that, I have done some fellowship courses. These fellowship courses are like just like as feathers on my crown. It's like no, it's increased my CV, and it increased. No, during my initial days, my salaries used to be higher than compared to other freshers after MS or DNB. So, and that is one thing. And second thing, this will be usually online courses. Here we are doing it, no, this is online. There won't be classes as per the board, but still we are conducting class to empower these students with basic knowledge. Okay, basic knowledge of this life-saving things and all. Plus, if students are interested, we are tying up with few hospitals so that they can come and have internship with few hospitals where we tie up around 2 to 3 months internship will be there, that you can come and learn practical thing. So that is one thing. And another thing is your salaries will be definitely high when you go to corporate setups or any other hospitals, because you have a degree, you are equipped with knowledge, and if people are ready to do internship, then again skills will be a little more enhanced. So this is the thing. So basically we want to improve the skills especially in technology and some medicines also. Plus nowadays we are empowering Ayurveda nutrition also, because there is you all knows about this doshas, so which can be corrected or maintained with this 3 doshas. So like that, we are starting nutrition courses in Ayurveda, so that when you are prescribing allopathy medicine, please you can empower your basic knowledge of, or your core knowledge of nutrition or medicines, like which enhances the immunity and all, so that the patient will be benefited maximum. So at the end of the day, patient should be benefited through our knowledge and skill. That's what we want to impart. Anil, anything?
That's it, sir. Thank you very much. Good night to all. Thank you.
Thank you.